Thank you very much, Noah. Thank you. Thank you for your interesting presentation, your clear speech. And on behalf of all members of the EasyNet project, we are very pleased and honored you accepted our invitation. We are very pleased to meet you and your team today with us.
Oh, the pleasure's mine. Yeah.
For your team, the other person know me. I am Nera Gabiti, an epidemiologist working in Rome with Marina Davoli at the Department of Epidemiology. And with Marina, we have been coordinating the EasyNet project, this complex network at Italian, at the national level, on audit and feedback. So Noah already received some abstracts of our project. So Noah, but this is the first time we meet him. And this project, Noah, started in 2019, and it is now going on. The end is scheduled in 2023, August. And various study designs have been implemented in different regions, Italian regions, and with the participation of many professionals and health operators. And we do hope to add to the knowledge on this topic. We do hope. And you gave us many suggestions, a very clear overview of the methodology, of the complex methodology of audit and feedback, and on problems that we are already facing with in our project. We are in the middle, and we have some difficulties, both due to the, in part due to the COVID pandemic, but not only, because it is very, we are trying to implement these methodologies very complex. So I am the honor to guide this second part of the seminar, the discussion time. And in the second part, Noah and all the audience, we will listen to some experiences from our EasyNet project in order to first let Noah and his team to know our context, our activities, aims, expected results. And second, to give elements to our today discussion of barriers, obstacles to audit and feedback strategies. And so I will invite to speak a researcher from each work packages, 5 out of 7, who will summarize in a few slides their work. After each presentation, Noah, you can take the floor and give us some comment or ask a question. But unfortunately, we have only few minutes, so only one or few comments is possible. And I like also to say that if anybody from the audience wants to comment, to ask question also to Noah, you can use the chat, you can write on the chat, and we can, at the end, in the last part of the seminar, we can open the discussion to the audience, trying to translate the question to Noah. So this is our program. Okay, so we can go on with our research team from EasyNet, Noah. And I like to invite to speak. The first one is Sabrina Licata from the north of Italy, Friuli Venezia Giulia. So please, Sabrina, you can start. You can present us, share your slide if you have. Each
Thank
speaker
you.
has...
Thank you, Nera. Thank you. Hi all. I'm trying to show my presentation. Here I am. Okay. Wow. As Nera told, we are in the north of Italy. Our team focuses is his work on emergency care in our region. The team has 3 groups. The first one uses real data. We chose more than 60 key performance indicators to try to describe our real life in the field of emergency. The results of our KPI are written in reports based on data of the previous year. We have already 2 reports. The first one was the 2019 on data of 2018, and the report 2020 on data of 2019.
Sabrina, scusami Sabrina, forse devi scorrere le slides?
No.
Ok, va bene sempre la prima soltanto?
Le sto scorrendo.
No, perché abbiamo visto solo la prima, scusa, parlo in italiano così. Ok?
E come è possibile che non si
potresti mettere la slide nel formato più grande? Quello, ecco.
Già fatto?
Adesso...
Dimmi adesso.
No.
No, non la vedo più.
No. Ma vuoi che la condivida io, Sabrina?
Perché vedevamo solo la prima, Sabrina, capito?
Allora, ripartiamo con la...
Metti un po' in formato grande.
Sono in condivisione, vedo in condivisione. Ho messo la presentazione.
No.
La prima. No.
Vedevamo solo la prima.
Se vuoi posso condividerla io, è pronta,
allora sì, dai.
Ok.
E mi vai dicendo quando cambiarla.
Forse riprendi dalla seconda, Sabrina. La prima si vedeva, la seconda è meglio che la riprendi. Scusate, parlo in italiano.
Ok.
Excuse me, Noah, we have a problem. Ok.
And
ok.
The third, please. Okay. Okay. Well, I was talking about our first group. As I say, the real life data. The problems we encountered with this group are also linked to the audit, but also to feedback. First of all, we had the difficulties in involving professionals to the process of choosing key performance indicators that were of interest. But we also had problem with reports because professionals didn't understand the importance of our reports, and we had low feedback, and too few people, in our opinion, read them. We tried to solve this problem by asking the cooperation of a local agency that coordinates the health authorities of our region. The aim is to find a common computation method on KPI, especially for those that are also of regional interest. The second group, the other slide, please. Thank you. The second group of our team works by data analysis. We try to integrate information of the local emergency call system to the territory. Friuli Venezia Giulia is a region that goes from the sea to the mountain, so a very different landscape, if I can use this word. The aim is to integrate the emergency call system infos to the territory in order to choose the best ambulance from the best emergency point, driving on the fastest route, also by thinking and traffic different in the different times of the day. We had a great cooperation of our computer scientists of our university here in Udine. The difficulties, we had problems in finding the right info to put in the data analysis because mostly because COVID pandemics it put the emergency call system as first line. So we had to try to solve this problem. Again, the key to solve this problem is to talk with authorities, with local authorities, and create interest on our system, not only for the actual scenario, so COVID pandemics, but also let them understand that there is a future. There's not only COVID, and so we can use this system to future scenarios. The other slide, please. Okay, the third group uses virtual reality. We developed a system that can be used by single professional to train skills and abilities in different emergency situations, all in virtual reality. The software can give an instant feedback to the professional who uses the program, and the session can be repeated as many times as the professional wants. So it's a single use. Also, in this case, we have a very great cooperation with our computer scientists of our university. Problem. The big problem is the official trainers of the region understand our software is not a substitution of the sessions with a trainer, with a real trainer, but it can be used as a retraining, not as a train for the first train. Solution, we try to involve the official trainers to the development and the optimization of our software, and also we asked to put the software in regional training program. This is the general panoramic. The last slide, please. Okay, in our future, for the first group, we are writing the third report on data of 2020, and we start the interrupted time series analysis. For the second group, that analysis, we are trying to refine the model with more specific information, the territorial jurisdiction of each ambulance and the crew. For the third group, we are writing a protocol to a real experimental protocol to evaluate the efficacy of our system. We are working and we are trying to solve problems little by little as they arrive. That is. Thank you.
Thank you, Sabrina. Thank you very much, Sabrina. Thank you. So I like Noah, if Noah wants to have just a few words on comment, or you have a need of clarification. Just a few minutes, Noah.
Yeah, just first of all, there's a lot of work happening. So congratulations, despite the pandemic, and
yeah,
you know, the world is upside down. And so I have a couple thoughts or questions. One is 60 quality indicators feels like a lot. And how will the recipients know where to focus? That would be my first question. And the second question, if you have time, is I mentioned in my talk that I think that educational feedback or skill development feedback is a little bit different than audit and feedback, clinical performance feedback. And I wonder if and how, when you're doing the virtual reality, you're using different, I don't know, conceptual frameworks than when you're doing the 60 indicators. So those are my two questions. Sorry, I should have one.
I'll try to answer. Yes, more than 60 KPI are a lot, are really too much. But the idea was to give general and as complete as possible. We have three major focus in our program. Myocardial infarction, so the KPIs for myocardial infarction are for cardiologists. Stroke, so the KPI of stroke are for neurologists, and major traumas. So even if there are so many KPIs, they can be
separated,
addressed to the right professional. That is the key to read our reports. We try also to explain this in a webinar last year. We will do the same this year. Maybe we are trying to find another way to show our work and maybe involve people and let them understand what we are doing.
Yeah, perhaps the Calgary model, I'll try to send you the paper, would be useful for these meetings or webinars.
Okay, thank you. Okay,
Thank you.
Sabrina. Thank you very much, Noah. So if we have time, we can go on with this discussion at the end, but we'd like to invite to speak the second speaker from Sicilia, Maria Cristina De Cola, Sicily.
Hi. Okay.
Maria Cristina, can you share the slides? Okay.
Yeah. I'm doing.
Vuoi mettere in formato più?
Perché non va? Ok.
Ok, bene Cristina.
This works. Okay. Hi, I'm Maria Cristina De Cola. I'm a statistician at the EX Centro Neurolesi Buino of Messina. It's in Sicily, South Italy. And I'm a team member of the work package 7 for the EasyNet project. So the aim of our work package is to improve the clinical practice in managing of cardio and cerebrovascular emergencies, with the purpose of reducing the mortality and the disability of the patients, both in acute and rehabilitation settings. So we designed a pre-post study with a control group and experimental group will receive a new feedback intervention. This intervention has been defined with the collaboration of a skilled psychologist and would be administered by using telemedicine devices. The setting are healthcare professionals involved in the acute myocardial infarction and ischemic stroke care factors. So we choose to focalize our attention on these two diseases because they are the simplest to monitor. at least in the acute stage, because there are a set of indicator, national indicator. They become from the Italian program, I mean the national program or accounts, is an Italian program developed to support the clinical audits performed to specific disorders like this one. So we choose to focus on acute myocardial infarction and ischemic stroke for these reasons. So we can use this indicator to compare our results and to measure the change, I hope, due to the intervention. We select a cluster of hospital provided by emergency and rehabilitation units, placed in the three main Sicilian cities, I mean Palermo, Catania, and Messina. State of the art. Okay, from the beginning of this project until now, we selected the hospital, and so we defined the sample. We fight to obtain the data. So we computate the indicators at baseline. That was formed the team. So this was defined the audited feeded the team, it was defined the intervention in collaboration with the psychologist. The team was trained to adopt a correct communication during the feedback from the psychologist. And we mailed 2 psychological self-report scales to the healthcare professionals involved in the care pathways. Okay, which obstacles did we find? Okay, first, we have some difficult to enroll hospitals. We had some difficult to enroll hospitals, and to plan the intervention because of the restriction due to the pandemic. So we decided to change our study design from a randomized control trial to a pre-post week control group, and the control group will not receive any intervention. Second. Okay, we are the only work package that we are not supported by the region. I mean the Sicilian local authority. What's this component? This means that we don't have direct access to data. So we bypassed the obstacles by opening a collaboration with the epidemiological department of the Sicily region. But the department computed the indicator for us. So we don't have data. We have directly the results, at least for the emergency indicators, because we have access only to the rehabilitation data.
Cristina, please, can you go to the conclusion, please? Because
yes.
We have a few minutes. Thank you.
Okay.
Thank you very much.
Okay. So we are planning to start with the intervention, and just which obstacle do we expect? Okay, first, we find that it's not so easy to define a new set of indicators for rehabilitation, because for emergency, in the emergency setting, there are a lot of indicators, but not in the rehabilitation setting. So we trying to define a new set of indicators. And second one, Second obstacle. Okay, we're afraid about the participation. I'm sorry, of the recipients, because in 1 month, so last month we mailed the psychological self-report, and now we received back only very little. I mean, briefly. So that's all.
Okay. Thank you, Maria Cristina. Thank you very much.
Thank you. Yeah, a couple of thoughts. I sent to Norina 2 papers that I think might be of interest to pass along to you, Maria Cristina. And my question is,
thank you.
What psychological scales are you measuring? And the reason I ask is that this is an area that I think we need further research to understand which people will respond to feedback, which won't, and why. It can be a great contribution.
We hope so. So the psychologist is trying to understand if there are some problem of communication inside the team. I mean, okay, it works in 2 different ways. So from the first part, it trying the team providing the audit and the feedback to have the right communication. No, this is about communication strategies, and in the same time, it is available to train the healthcare professionals in case of some discussion or some problems relates to the care pathway, because he thinks that could be some problem inside the team in just to improve the communication between the healthcare professional could be obtain better results to improve the care.
Noah, we can listen to you, Noah. No. Okay, we can't listen.
We're about to do something similar on using psychological scales with teams, and it would be good for us to connect, I think.
Okay, thank you very much, Noah. And then I would like to invite Giulio Marchesini. Is there in the audience, Giulio? Are you here? Because Giulio has a problem to stay with us all the meetings, during the whole meeting. So if you are here, Giulio from Bologna, you can start your speech.
Yes, thanks. I'm here.
Giulio, 5 minutes, not more, because we have little time. Okay.
Can you see me?
Yes, we can see you, but not the slides. And I don't know if you have some slides, no? A short presentation.
Yeah, and the slides are.
You want us to share the slide, Giulio?
Yes, I'm trying to.
Se vuole, Giulio, possono mostrarle loro.
If you can share my slides,
you can. Yes.
Find my slides.
Eccole.
Okay.
Eccole, Giulio.
Thanks. And this is my first slide, and we can go on to the second. The Emilia-Romagna region was intended to test the effectiveness of audit and feedback to improve healthcare practice in type 2 diabetes mellitus and chronic heart failure. And the aims were to develop an audit and feedback initially based on administrative databases, and to implement and test the impact of this audit and feedback in specific areas of the regions that are the healthcare units involved in the program. And finally, we planned to enlarge our audit and feedback based on the analysis of patients and physician needs. And we did a lot of focus group inside the participating units to identify these needs of patients and physicians. And we intended to design an audit and feedback that might integrate the classical administrative data with the results of the focus groups, and also with the sources that were available in a few areas, particularly with social demographic data, and which are available, for example, in the area of Bologna. If you can move to the next slide. Okay, thanks. And this is what we did, and the focus group were highly effective, and we could identify several areas of difficulties from which were originated by organizational problems. For example, the existence of waiting lists and the difficulties to reach the hospital for patients who had to be seen by specialists, and also a lack of availability of resources, and also the needs in terms of patients, because they claimed that there were a lot of difficulties. For example, the competence of the specialists, or the organization as a whole, not really of the specialists, and the communication abilities. You have to consider that the area where I live is an area where there is a lot of immigration from South Far East, or from Northern Africa, and we have a lot of people who speak badly Italian, have a very poor language competence. So it's quite difficult for family physicians and also for specialists to integrate with them. The demographic transition is another problem. That is, most of the patients we were intended to target are patients with a lot of, are very, very frail. And this means that it's very difficult for them to attend the hospital. And to complicate everything, we had to cope with the SARS-CoV-2 pandemic. And these two types of problems, of diseases, that is non-communicable diseases, were totally moved from inpatient care to web or IT communication. What comes from all these problems is that we should also take care of our patients by means of an holistic approach, not limited to the analysis and the treatment of diseases, but we need to expand our consideration to the social determinants of health. And social determinants of health that definitely act in a multidisciplinary way, within a multidisciplinary perspective. And the problem was the model of care, the pre-planned model of care, what we call the percorsi diagnostico-terapeutici, should be coordinated, because, for example, we have patients which are both in the model of care of diabetes and in the model of care of the chronic heart failure. And what definitely emerged as a problem was that we need more frequent feedbacks to the professionals in order to improve their activities but these feedbacks should be very easy to use in daily practice. Can you go on to the next, please? And the state of the art is that we were definitely to cope with the pandemic, and this was, for example, in my specific areas, regional area, was very, very impressive during the first surge in March, April, and May 2020. And the epidemiology units were involved initially in the analysis of disease and later in vaccine injection and in all the arrangements which are needed. And also the primary care physicians had to cope with a lot of difficulties with their patients, and they were definitely not, we were unable to involve them in these activities. So this was a reason for a delay, and we had an additional problem here in Bologna because we have two different databases. One belongs to the university hospital and the second is part of the local health unit. And unless we merge these two databases, it's very difficult to have solid data on the targets we had fixed in our analysis. And it took a lot of time to make this sort of merging, and but now we have solved all the privacy problems, so we hope that this will be done soon. And we expect to have our analysis completed by the end of 2021. Is there another one, or is that? Oh yeah, and so we are now in the implementation of our feedback to primary care physicians and to what we call primary care units, that is groups of primary care physicians. And we are expected to compare the results of the initial analysis during the year 2019 with what we shall measure during the year 2022 using a more intense report frequency. And the 2 years, that is 2020, 2021, will be in some way an intermediate part of the analysis, because due to the impact of pandemic, it would be quite difficult to compare the results with the 2019 and the 2022, at least we expect. And we have also make arrangement with Regione Lazio to have the same protocols, and this might be useful to have a benchmarking, and we might also use national collections for have a larger benchmarking in order to have a systematic analysis of what is going on in the area of Bologna. And the obstacles now seems to be solved, but we must be very careful before saying that, because at present we are seeing a resurge of pandemia, and this might put all the analysis at risk. And we hope it will not be the same, but this is a problem we have to consider in our planning. Okay, that's all.
Thank you very much, Giulio. Noah, if you agree, we would prefer to go on with the last two speakers and then to discuss it together at the end, Noah. We would like to go on with the two speakers. So I would like to invite to speak Gianni Ciccone from Piemonte. Prego, Gianni.
Thank you, Nerina. Do you see the presentation?
Sì, bene. Well,
Okay. In our region, we are going to conduct 4 interventions of audit and feedback in oncology. The first one was on ovarian cancer, and it is almost completed. A second project was on bladder cancer, and is ongoing. And the last 2 interventions were focused on the implementation of the ERAS perioperative protocol, the enhanced recovery after surgery protocol, in all the regional hospital network. Very briefly, the 2 studies involved a population of all consecutive patients with scheduled surgery for colorectal cancer or for hysterectomy. The setting was all the regional hospitals in Piedmont that included 32 hospitals with a general surgery and 25 hospitals with a gynecology unit. The trial design was a stepped wedge cluster randomized. The 2 studies were conducted in parallel. The patient enrollment lasts 21 months and were included more than 2,000 patients in each study. The audit and feedback strategy was the same in the 2 interventions. We organized the presentation and training meetings at the beginning of the interventions, then developed a study website that was continuously updated with a database, a monitoring area to monitor study patient enrollment for each center, and a feedback area that was activated during the intervention period with a graphical representation of the adherence of each center to the protocol items with radar graphs and histograms to compare centers. We also produced periodic reports with indicators of protocol adherence and organized online meetings. At the end of the study, we did a survey of participating centers to collect local experiences with obstacles, encountered, and perspectives. And last month, we organized 2 presentations of the results of the 2 studies. Very briefly, the main results of the study were a moderate or even high impact of audit and feedback in improving adherence to the ERAS items. The improvement was on the average of 14 points from comparing the control to the intervention period. But we also detected a high heterogeneity among centers. We observed also weaker effects of the ERAS protocols on clinical endpoints. For example, mean length of stay decreased in both studies, but to a lesser degree with respect to what was expected. But we noted also a clear trend towards greater clinical effects with higher adherence of the center and with increasing time and experience. In this graph is clearly evident that most centers reached important improvements, but few centers achieved only minimal or no improvement at all. What were the major obstacles that we detected? We detected these problems through the survey at the end of the study. The first was not very original indeed, but the lack of involvement of local leaders. This happened in few centers, but was with a very negative impact on the results. Also, a general cultural resistance and skepticism toward innovation, especially in older people. This is a well-known obstacle to any change. Also, lack of time for data collection was a problem. This is typical in Italian hospital for the lack of data managers in the health system. And also a very negative impact was due to the shortage and the high turnover of personnel, especially nurses and anesthesiologists, and last but not least, the COVID pandemic. Some factors were reported as positive factors. The involvement into a research project was appreciated, especially by small and middle hospitals that are usually excluded from research projects. The audit and feedback strategy itself was reported among the positive factors. The regional health department had a very positive role. It was also appreciated the strong central study coordination. Another positive factor was the experience to work in multidisciplinary teams, and also the increased staff motivation and patient satisfaction. What are the problems that we are facing now? Obviously, it is very difficult to maintain a systematic collection of detailed clinical data outside research project. And therefore, there is a great risk of progressing, abandoning of new protocols. We are aware that there is a need for additional time to consolidate the changes. And hopefully the COVID pandemic will no longer represent a major problem. The perspective are to allow centers who are interested to continue the collection of clinical data to use the interactive website that was developed for the study. We are planning to produce periodic reports based only on routine data every 6 months, and to organize during the next year courses on ERAS and meetings involving the hospitals to promote exchange of experiences among regional centers, and also to extend the ERAS protocol to other surgical procedures. Well, that's all for now.
Thank you very much, Gianni, for your very clear and interesting presentation, Gianni. Thank you very much. We would like to go on with the last speaker, Anna Campora from the Lazio region, the coordinating center, and then we'll go on with the general discussion with the NOAA, with all the audience. Please, Anna, you can go, you can start.
Thank you, Nera, and hello to everybody. Thank you to Noah also for this collaboration opportunity. I try to share my screen. Okay. Can you see my first slide?
Yes, that's okay.
Okay, thank you. Okay, as Nera said, I'm Anna Campo. I'm representing the work package one, developed by the Lazio region. And the work package one is about a comparative effectiveness evaluation of audit and feedback strategies to improve integrated healthcare models for chronic and acute conditions. So we in the work package one, we have three objectives. The first one in general was to identify process and outcome indicators to be used in the report activities for the feedback activities for two different kinds of disease, chronic and acute conditions. The second objective was to assess the comparative effectiveness of three kinds of feedback strategies dedicated to improve healthcare for patients affected by diabetes, COPD, and chronic heart failure. And the third one was to evaluate the effectiveness of different strategies of audit and feedback for improving appropriateness and timeliness of emergency healthcare interventions for patients affected by acute myocardial infarction and stroke. So in order to achieve our objectives, beside the definition of indicators, we defined two different research activities, line of research. One dedicated to audit and feedback in emergency care in hospital settings, and the second one dedicated to chronic care in community settings. As for the first field of research, our study design is a pre-post intervention study with a control group. And in this case, the target of the intervention are hospital teams in cardiological and neurological area, but also representative from Regione Lazio and from pre-hospital emergency system are involved in this project. The intervention group, in the intervention group, we will send periodic feedback reports every 6 months, including indicators, outcome and process indicators at hospital level, together with a reference system, including standard of care, benchmark, regional mean, and best performers. Along with this feedback, we will send to our target also guidelines for conducting audit meeting after receiving each report. And also we will collect audit characteristics using a structured form. For this research line, our control group receive usual reporting activities through the Prevale website. The Prevale is a regional web-based platform publicly available that regularly publishes several indicators for several chronic and acute conditions, including also acute myocardial infarction and stroke. Similarly, for the second field of research, the study design is a pre-post intervention study with control group. In this case, our target are mainly general practitioners that will receive indicators calculated on their own patients. The control group is the same. In the control group, general practitioner will have these user reporting activities available, but including indicators for chronic conditions in this case, so diabetes, COPD, and chronic heart failure. In this case, we have two different intervention groups, a middle intensive intervention and a high intensive intervention. In the middle intensive group, we will send periodic feedback reports every 6 months, including indicators calculated at a general practitioner level and compared to a standard of care, if any, to the mean results at the level of a group of GPs working together, mean results at the health district and the local health authority level in which the GP work. For the high intensive group, in addition to periodic feedback, general practitioners will be also invited to participate in periodic multidisciplinary and multi-professional meetings in which they could discuss critical indicators, related problems, possible solutions, together with involving also medical specialists and representatives of the management of the health districts. These meetings will be integrated also within an educational and training course, mainly about guidelines for the management of the diseases considered and about the audit and feedback methodology. What we have done until now for the emergency care research, we completed the hospital recruitment. We carried out a baseline survey on the level of knowledge, application, and characteristics of audit and feedback methodologies at the hospital. We conducted a consensus development about the indicators to be used for the feedback activities using modified Delphi methods. And we drafted and shared with participants the form for the collection of audit characteristics. As for the chronic care research line, we completed local health authorities and districts recruitment, and we are completing also GPs recruitment within each district that we have recruited. We also selected and defined the indicators for the report, and we will discuss this indicator with GPs. We are also developing the educational and training course on clinical guidelines and audit and feedback methodologies. And we are also developing an interactive dashboard for the consultation of indicators as an alternative to PDF reports. So our first report will be a PDF report, but we hope to develop this dashboard for the second release. In this period, we tried to collaborate with all the involved stakeholders for each decision we made. Until now, the main obstacles and proposed solutions besides the pandemic spread. Here we can see our obstacles. So the first one we experimented was difficulties in hospitals and the local health authorities and districts and GPs recruitment, or because they decline or no response to invitation. A solution in this case, we modified our study design from an original randomized control trial to the pre-post intervention study, and we recruited on a voluntary basis. For the pre-post intervention study, we will use 2021 as pre-intervention period. A second obstacle regarded the data that we are using. I did not mention this before, but we are using health administrative databases. So some obstacles are related to the incompleteness of this data and of the timeliness of this data, particularly now during the pandemic period. Problem with the data sources, we will discuss this problem in audit during the audit, and we will collect possible problems and possible solution also from participants. So we will collect and highlight critical points, possible solution as final results of the project, and to point out this in the final report. Furthermore, we are also integrating our research activity with the qualitative research. We are developing different survey in order to evaluate knowledge, attitudes, and behaviors of physicians about audit and feedback, and also about obstacles and favorable factors. Another obstacle that we have experimented is the perception that the intervention is imposed, or the intervention as a mere judgment on the practice of the target, or just for research interest. To deal with these obstacles, we are trying to share decision and co-design several characteristics and steps of the intervention with all the involved professionals. And what we will do in the next future, we will send the first feedback on January 2022 for both the research line, and we will conduct the first meeting series about this feedback data. And on January 2022, we will collect the pre-intervention survey about knowledge, attitudes, and behaviors of the professionals involved. And furthermore, for chronic research line, we will start with the educational and training course on January 2022. As we made also before, we will continue to collaborate with the involved stakeholders in defining a specific characteristic of our strategies and sharing decision with all these stakeholders. So thank you. This is my last slide.
Thank you, Anna, for your presentation, for this summary. So Noah and all the audience, we have about 10-15 minutes, if you agree, till 5:30, okay? And if you want to go on with the general discussion, Noah, if you had an overview of our project, you have seen the heterogeneity and the complexity. So we would like to have just some comments and specific questions you want to the last three speakers. Please, Noah.
Yeah, thank you. So first of all, thank you, everybody. And I'm sorry if I spoke too long and made everybody else rush. I have some questions for each, but I think one of the things that comes out from hearing everybody speak is that there are some scenarios and also indicators where audit and feedback seems more likely to be effective than others. Yeah. And it sounds straightforward when you say that. The problem is that we want to be able to better predict that ahead of time so that we, spend our time doing audit and feedback where it is likely to work and do other things in other scenarios. It strikes me that the perioperative or preoperative testing is an area where a few times now audit and feedback has been proven very, very effective. And I'm not sure we understand very well why it works really well with that and not as well with chronic disease management. We can guess, but we don't know very well. And I think across the projects, there's an interesting question to ask perhaps about comparing which scenarios seem to work better and why, and try to unpack that.
Yeah.
The other cross-cutting question relates to one of the things that you said earlier, which is that there is a goal here to understand the impact of audit and feedback on equity. And one of my concerns has always been that engaging in audit and feedback is typically voluntary. And so in my experience, frequently doctors that are already doing very well decide to go engage, and maybe they do even better. And there is a concern I have that maybe the spread of inequities or variation across populations gets worse as a result of us making those who are above average even better and leaving those who need help over here unsupported. And I think it would be interesting to understand across all the packages and the projects, whether that is a risk or not and how we might address it. I'll stop speaking there.
Okay. Thank you, Noah. So that's okay for you? Don't you have any? I think that this is a starting point, if you agree. We met you and you know our project, so I think we can go on. We keep in touch with you and your staff. This is the reason why we had the honor to meet you today, just to have a starting point to continue. As I said before, we are in the middle. The project is complex, so you understand that there is a large heterogeneity also in the timeline, in the expected and obtained results till now. As I said before, we are also besides going on in each regions with each project. We are from the beginning, we are doing an effort to share methodology, instruments, and to build a net. So we would like to build, as you say, an audit and feedback laboratory, Italian laboratory. So this is our dream, our effort, and we do hope to reach these results. And we thank you very much for your comments, for your time with us. I don't know if Marina or everybody in the audience wants to add something, other comments, other colleagues from Canada or from Italy. And otherwise, I don't know if there is Marina.
Thanks, Narina. Yes, if
Marina,
no one else or while there is someone who wants to talk, I found this. Thank you, because I found this all the presentation interesting, and I think the common what I got, the main message that I got from among the many from Noah, that is indeed what we are trying to do, and I think what makes it even more difficult is the embedding of this research activity into the healthcare mission. As you have seen from many of the presentations, the effort is to move for what could have been, let's say, a limited research project, which probably could have had some, let's say, easiest results. I don't know if yes or not, but the challenge is in all the work packages, because they are all in almost all work packages, to make it part of the system. And so to use the same KPI that are used by the system and help the system to use better KPIs, I mean, in a sort of, so I think our challenge now, at least, I mean, the main challenge, I think, in Italy is to spread the culture of audit and feedback. Because we really, there is not, this culture is not there. So we really have to do a lot of effort, and we need to find a way to, so on two sides, I think. One is, it is something like, it reminded me a little bit when we started to work on spreading the culture of evidence-based medicine. That was something that there was so much resistance, and also I think the way we did probably was not the best, because we know that we didn't have those results that we expected or we wanted to have. While in this case, the evidence-based medicine is proposed as something that goes that is not imposed, but is part of the culture, of the quality improvement, etc. And when you said that talking about equity, that we expect is what we say, are always the same, that participate because they have this sensitivity and they are open to change, while most of our professionals and system, there is a lot of resistance. So I think it's really a big effort and challenge that will take time. On the other side, I think that if we manage to focus on a couple of research questions that you have highlighted and that are of international interest, we could see how we could collaborate across the different work packages, having as one laboratory, and see how we can design studies to test together some of the hypotheses that you have raised, because I think this would be a way of increase the research culture, but also to transfer them into clinical practice. So I really hope we can go on, and I really think that some of the researchers that have spoken today will commit themselves to contact your group again and maybe organize a sort of more operative workshop in designing something together.
Yeah, I would be very excited to hear from any or all of you, and if there's any connections I can make with people I know that are doing things in your area, I would love to make that connection. And also want to encourage people to attend the Audit and Feedback Conference that's coming in a couple of weeks. And I know that Norina will send, I guess, information about that. It's online and it's free. And maybe that is another way that you can hear about people doing things with similar research questions to you. Yeah.
Thank you.
Very good.
Very good. Very good. So Norina from Pensiero Scientifico, I thank Norina and her staff for organizational aspects, technical aspects, and Norina will be the person who will give you the contact of each of us, of our teams, so by mail. And as Marina said, we will do hope to meet you again with a more operative seminar, video call, if you agree. So in the next few days, video recordings of this seminar will be uploaded on the EasyNet web page. So I think it's time to conclude, Noah, and all the audience. So we thank everybody. Thank you, Noah, for your time, your precious collaboration, and stay with us, your staff. I thank Marina Davoli for her time with us, and all the audience. So good afternoon to Italian people, and good morning to you, the Canadian.
Okay.
Thank
Bye-bye.
you. Thank you very much.